Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME meetings. Today, one of transplantation lectures. We are pleasure to have Professor Ziad Zaky, Professor of Nephrology. He is Assistant Professor of Medicine in Cleveland Clinic, USA, and he is in Glickman Urology and Kidney Institute, Case Western University. Dr. Ziad will speak about an important topic in transplantation, how non-invasively diagnose transplantation issues by the use of biochemical markers. We are honored today to have our moderator, Professor Gamal Saadi, who is the Emeritus Professor of Internal Medicine and Nephrology, Cairo University, the past president of Cairo University Dialysis and Transplantation Center, past president of Egyptian Society and Transplantation of Nephrology, Egyptian Society of Nephrology and Transplantation, and the current president of African Society of Organ Transplantation. We are honored today to have our great moderator and our great speaker, Professor Ziad. So I will leave the floor to Professor Gamal to lead this session and further introduce Professor Ziad before we go to the lecture. So please, Professor Gamal, take the floor.
Bismillah ar-Rahman ar-Rahim. Good evening, everybody. It's really a great pleasure to be listening today to Professor Ziad Zaky. He's the Assistant Professor of Medicine at Cleveland Clinic at United States. He's the Director of International Transplantation and Kidney Care in the Department of Nephrology, Hypertension, and Transplantation. Professor Ziad was graduated from Asr Al-Aini, Cairo University in 1995. He had a lot of important positions, including that he's instructor of clinical medicine at Columbia University, and he was the assistant professor of the College of Osteopathic Medicine, Michigan, with a terminology section very interesting. And he had a lot of experience and practiced a lot of positions, including important aspects which are very interesting to me, including emotional intelligence, economics for managers, medical biostatistics, clinical epidemiology, and this is in addition to his clinical experience in nephrology and transplantation. Professor Ziad is going to give us his talk about non-invasive biomarkers in kidney transplantation, and I'm expecting to hear and learn from him a lot about the biomarkers of rejection, biomarkers of tolerance, biomarkers of fibrosis, and any of them which are immunosuppressive dependent, what is not immunosuppressive dependent. And we are very eager to listen to all aspects of this non-invasive biomarkers, which is now mandatory and very crucial in our transplantation practice. Professor Ziad, the floor is yours, please. Fadl.
Thank you. Thank you for hosting me. And I will try to be focused in this discussions and this about non-invasive biomarkers kidney transplantation. What is the current status right now in United States, especially in the clinical practice? I'm not going to allude too much on the basic science research, and I'm trying to be more focused clinically. So I have a disclaimer here regarding this presentation, and that's because I was involved in many of the clinical trials of these non-invasive biomarkers for rejection. I was co-investigator for the DART study, which I'm going to talk a little bit more in the next few slides. And I'm principal investigator in many of other studies for non-invasive biomarkers in the Cleveland Clinic site. So as an outline for the presentation, I'm going to talk about the need for non-invasive monitoring, evolution of cell-free DNA, the DART study, And why especially the DART study? Because this was a landmark study where the clinical use of non-invasive biomarkers, the cell-free DNA, has been validated and was approved by FDA and reimbursed by Medicare. There's other non-invasive biomarkers like gene expression profile and urinary biomarkers, and there is limitations and some unanswered questions that further studies will hopefully answer these questions. So as a background, there is definitely data, and this is from S-Data, about the long-term outcomes following acute rejection in kidney transplant recipients. And this is based on 13,000 kidney transplants over a 20-year period and more than 2,900 rejection episodes, especially in the acute rejection the first 6 months. And it showed definitely that the acute rejection the first 6 months has an impact on the graft loss and the patient's survival. And you can see the hazard ratio in terms of acute rejection, chronic allograft nephropathy, as well as increase in patient deaths and mortality. But also not only acute rejections, but even subclinical rejections detected in the first 6 months, or at least in the first year after transplant, it also has an impact on the graft survival and patient survival. This was a single center study based on more than 400 kidney transplants over a 3-year period. And it showed that even with a subclinical inflammation, like isolated I0T1 or I1T1, it has an impact on the patient and graft survival. In this study, there's about 31% subclinical inflammation on surveillance biopsies in the first year. And they showed in the next slide that the composite endpoint from terms of acute rejection, whether T-cell or antibody-mediated rejection, and death sensitive graft failure, it did have some negative impact on the patient and graft survival. So now we have the first problem is that acute rejection or subclinical rejection in the first year has an impact on graft and patient survival. So that makes the argument for surveillance biopsies and potentially rebiopsy if there is a subclinical injury and need to be treated. On the other hand, there's a UNIS survey from 2017 showing that only about 18 centers from the responders, only 18 centers in the United States perform surveillance biopsies. And maybe another 22 centers perform biopsies for selected cases. So there is definite need to have a better way for surveillance, since we're not doing a good job in doing surveillance biopsies. Even in our center, we've been doing 3, 12, and 24 months surveillance biopsies. We stopped doing the 24 months, and we have been only doing the 3 and 12 months surveillance biopsies. So basically, there is an unmet need here with standard of care. You have serum creatinine and GFR that may be lagging behind the rejection, maybe not specific. On the other hand, you have renal biopsy, which can be invasive, costly. There is a risk for complications, and it's logistically, sometimes it's difficult to perform. So this is where we at now. We have less invasive markers like serum creatinine, donor-specific antibodies, and we have more invasive, more accurate doing kidney biopsy. So where there is an unmet need here. And this is where the cell-free DNA about 5 or 8 years ago came up into light. So it's a non-invasive biomarker, but also it is kind of more accurate than the creatinine when we try to detect for rejection. And this is where we have here. Can the donor-derived cell-free DNA can avoid complicated biopsy? Patients who are on anticoagulation, obese, those intraperitoneal kidneys. I can tell you that from my clinical practice that I have patients with BMI of 40, and I have to do biopsies for them. We're talking about 160, 170 kilogram patients that we need to do biopsies for them. There is a need for surveillance biopsies to detect subclinical rejection, for immunosuppression management, for patients with high CPRA. And also at the same time, we have biopsies where we get this report is that it's equivocal, maybe, maybe not, there's a rejection. And there is also need for re-biopsy patients after treatment for rejection. So this is where the donor-derived cell-free DNA came into light, and a lot of studies have been involved. So what's the science behind cell-free DNA? So it's a non-encapsulated DNA in the bloodstream. It enters the bloodstream if there is any cell injury. This cell injury can be apoptosis, necrosis. We knew about it since 1948, has a short half-life, and the clearance is not well studied, but most people say it's more of a liver clearance. And there has been several uses for cell-free DNA. There's fetus cell-free DNA, tumor, donor, and self-cell-free DNA. And if we look at the history here, so started in 1948, were discovered, maybe until 2011, where the cell-free DNA was used to detect any genetic abnormalities in pregnant women. In the last 10 years, cell-free DNA has been used for tumor markers and for detection of cancers. And maybe still until 2017, we didn't know if can we use donor-derived cell-free DNA to monitor rejection or no. And what is exactly donor-derived cell-free DNA? You have the patient DNA, you have the donor DNA, and you want to detect this, what we call single nucleotide polymorphism. So you have a donor with the amino acid base pair here, where it's this very similar to the recipient, but when it comes to the cytosine guanine, this base pair is different from the recipient. And if you detect more of those differences between the donor DNA and the recipient cell-free DNA, the recipient's DNA, you may be able to find those patients with rejections. So it's very important, the SNPs, because I'm in the next few slides, there's a discussion about the SNPs and different techniques. So the mechanism, the basic mechanism is that you have a cell injury from the kidney, the transplanted kidney. The DNA is released into the patient blood, and you measure the amount of the cell-free DNA that has different SNPs than the recipient. And if there is a high level, you can say that there is a high likelihood of rejection, and maybe we should do a biopsy. However, there are other factors that affect the DNA, the cell-free DNA. And because you are measuring a percentage of the donor to the recipient, so we have to put into the equation all these variables, like high body mass index, there is normal variation, in addition to presence of rejection. So this is a DART study where I had the pleasure to be part of this study. And this is why it's landmark, because this is where FDA, Medicare approved cell-free DNA to be used to monitor for rejection in transplant patients. This was a multi-center study. Jonathan Bromberg from University of Maryland, Dan Brennan from Johns Hopkins, Emilio Poggio and myself from Cleveland Clinic. There was David Cohen from New York Presbyterian and Roy Bloom from University of Pennsylvania. So multi-center study. There's Stanley Jordan from California as well. So in the DART study, there was 14 centers. We recruited 384 patients. We had a lot of biopsies in those cohorts. Patients were enrolled over almost a 1-year period from April 2015 to May 2016. And we had serial blood samples for those patients, correlating serum creatinine, donor-derived cell-free DNA, and their biopsies as well. So in this cohort, we had 75 patients with no active rejection and 27 patients with rejection, different types of rejection, 10 with chronic antibody-mediated, 6 acute antibody-mediated, and 11 T-cell-mediated rejections. So in this slide, it shows that we had to put a line where it would be considered normal and where it would be considered abnormal. And the line was the presence of 1% or more of donor-derived cell-free DNA in the patient blood. And we found that more than 1% was associated with type 1B T-cell-mediated rejection and a lot of antibody-mediated rejections. And this is an important number because this is where in the clinical practice, nowadays, we use the 1% mark. If more than 1% of donor-derived cell-free DNA in the patient blood, this is a very likelihood of having some sort of cell injury, namely rejection and the need for biopsy. And the cell-free DNA was even more sensitive than serum creatinine in this cohort. So if you look on the right side, the serum creatinine between the active rejection and the patients with no active rejection was about the same, maybe around the 2 level. But when we look on the left side, the difference between the cell-free DNA between those who had no rejection versus active rejection, it seems that at the mark of 1%, we captured more patients with active rejection. So donor-derived cell-free DNA can differentiate even with the patient having a baseline. At the baseline, creatinine can differentiate between rejection and no rejection. So further studies showed that the median level of donor-derived cell-free DNA for antibody-mediated rejection was about 2.9%. So, and that was an 85% positive predictive value. Also, in the study, we found that if you have, and I'm going to use because in the study we used AlloSure, which was a product that was available at that time. And we found that if AlloSure is less than 0.2%, you have a 95% negative predictive value to rule out rejection. So it's a very good rule out test for monitoring and surveillance. I will get to the RCV of 61% in the next slide. So in the DART study, the conclusion is that you have a median donor-derived cell-free DNA for antibody-mediated rejection about 2.9%. For T-cell-mediated rejection, 1B, 1A, about 1.2%. And your control group was negative rejection was about 0.3%. And if you take the 1% cutoff you have 80% specificity and 81% sensitivity to detect antibody-mediated rejection. So it's a very good test for antibody-mediated rejection, not as good for T-cell mediated rejection. So what is RCV? It's a relative change value. As I mentioned earlier, that there's a normal biologic variation of the cell-free DNA and the donor's cell-free DNA. So what about patients who have an increase in the donor cell-free DNA? It's still less than 1%, but for example, increased from 0.2 to 0.8. So in the DART study, we found that those patients who had an increase of 61% from the baseline, even though that they are less than the 1% threshold, it still was significant and necessitated biopsy, and there is quite a bit of inflammation in these biopsies. So the takeaways from the DART study: donor-derived cell-free DNA less than 0.2% has 95% negative predictive value for active rejection. At 1% cutoff, you have 83% specificity and 81% sensitivity to detect antibody-mediated rejection. Serial increase in donor-derived cell-free DNA, more than 61% from the baseline, that will require biopsy. There's a likelihood of having some sort of inflammation in these biopsies. But as any study, there was limitations in the DART study. First of all, there's a small number overall of rejections. The donor-derived cell-free DNA did not differentiate between T-cell mediated rejection and normal biopsies. And in this cohort, we have 2 cases of BK BK virus-associated nephropathy, and we're associated with very high level of donor-derived cell-free DNA. So further study, we've been trying to tease out the BK van from the T-cell mediated rejection, other rejection, but not as of now in clinical practice, we can differentiate between the BK van antibody-mediated rejection or T-cell mediated rejection using only this donor-derived cell-free DNA. Now, there's always this controversy about those cases of borderline or T-cell mediated rejection 1A. Should we or shouldn't treat? And there's a debate about this. So in the next slides, there is more recent studies showing that the borderline rejections, they're not behaving similarly. And maybe if you have I0T1 versus I1T1, you may have worse outcome in terms of graft survival. So then came the study called RADAR study. And basically in RADAR study, they were trying to differentiate between this T-cell mediated rejection 1A versus borderline, which one need to be treated, which one maybe it doesn't need to be treated. So the patients were stratified according to their cell-free DNA, less than 0.5% versus more than 0.5%. And they were followed by serum creatinine paired biopsies. And they looked at the outcomes of change in the GFR, formation of de novo DSA, and whether the patients had recurrent rejections. Interestingly, that in this study, if you have patients with T-cell mediated 1A or borderline, and their donor-derived cell-free DNA is more than 0.5%, there's a very statistically significant decline in GFR, development of de novo DSA, and recurrent rejection, versus those patients who had the same biopsy findings with less than 0.5% donor-derived cell-free DNA. So it's a marker of active rejection, even though that you may have the same pathology. So the takeaways from the use of donor-derived cell-free DNA in clinical practice: more than 1%, very high likelihood of having antibody-mediated rejection, not as much for T-cell mediated rejection. Less than 0.21%, you have a good 95% negative predictive value to rule out rejection. An increase from the baseline about 60%, this is significant. Probably you need to follow those patients, maybe get a biopsy. Even for the same biopsy findings of borderline or T-cell mediated 1A, if you have an elevated donor-derived cell-free DNA, there is likelihood that those patients are the ones that need to be treated. So moving along about other biomarkers, there is a gene expression profile. And gene expression profile is a bit as a science or application is a little bit lagging behind the donor-derived cell-free DNA. So currently, we have 2 gene expression profile tests available. One is called TrueGraph, and it detects 120 genes. And one is called AlloMap Kidney, and it detects 5 genes. Now, why I'm mentioning that? Because so far, when you get a report about the TrueGraph, it's qualitative, means that it tells you whether there is rejection or no rejection. It doesn't give you a score. And the AlloMap Kidney, why it's called AlloMap Kidney? Because 10 years ago, for the last 10 years, we've been using a gene expression profile test for the heart transplant patients. It consists of 20 genes, and it's called AlloMap Heart. So we found that out of those 20 genes used for heart transplant patients, 5 genes are more specific for the kidney rejection. The good thing, it gives a scoring system, quantitative. So the TrueGraph was mainly like Northwestern University is mainly taking the lead in discovering the TrueGraph and application of the TrueGraph. And this, they had a study, actually multiple studies, to validate using this gene expression profile called TrueGraph, using the 120 genes signature for rejections. But they only report as TX and not TX. What does it mean? If the patient has low expression of these genes, we call this transplant excellence, TX, means that probably you're going to have normal biopsy. This is stable serum creatinine. There's what we call immune quiescence. Versus not TX means that there is high expression of these genes, and you are very likely having rejection if you do a biopsy. So not very satisfactory, but this is how it came up in the practice. And this is based on several studies. Maybe the most important one is that when they had 192 patients and they had 75 stable versus 24 patients, done TX based on biopsy, and it was published in Transplant Proceedings 2019. So based on their studies, based on the validation of TrueGraph, it has a negative predictive value of 91%, specificity and sensitivity, maybe not the greatest, around 70%. So the gene expression profile by itself maybe should be used as a complementary to the donor-derived cell-free DNA. This study is for the other gene expression profile available. It's called AlloMap Kidney. And they studied these 5 genes. As I mentioned, this is 5-gene classifier. mainly were adopted from the AlloMap heart, which has 20 genes. And the good thing about it is that it's a quantitative, so you get a score. And if you have a scoring of 11.5, this achieved the maximum accuracy of sensitivity and specificity. And basically, these are the 5 genes and how their implication. Now, I have to be here as a disclaimer is that the final validation for using this test hasn't been yet. There is a study, ongoing study. We have some preliminary data called KOR study that we combine both the donor-derived cell-free DNA and this gene expression profile, awaiting final data probably by the end of this year. But in the preliminary studies for using AlloMap, it helps. Maybe the AUC was 0.7 versus rejection versus no rejection. It has, if you look at in the middle, normal versus TCMR, T-cell mediated, antibody mediated, or mixed rejection. So maybe if you have a score above 11.5, you can detect those by the gene expression profile. So basically, if you can combine both tests, the donor-derived cell-free DNA and the gene expression profile, you may enhance the performance of the tests. And this is where you have here you can pick up some of those cases of rejections here that otherwise the donor-derived cell-free DNA is less than 1%. You can detect them by using the threshold of 11.5 for the gene expression profile. And here it showed that maybe by combining both the donor-derived cell-free DNA and the gene expression profile, you may enhance the AUC to 0.8. So not perfect, but may help. Now, the urine biomarkers. And I have to tell you this, that in the urine biomarkers, the technology is still behind. The most promising is based on New England Journal of Medicine 2013 from Suzanne Theran from Cornell, using 3 urine biomarkers for detection of acute cell rejection. And these biomarkers using the urine messenger RNA, the CD3 epsilon, CXL10, and 18S ribosomal RNA. And so why the urine biomarkers are a little bit lagging behind? The problem is that the markers are mainly messenger RNA. And the messenger RNA, the problem with the RNA is very easily fragmented, not stable when it's taken. And you have to put these samples in what we call RNA later, preservative. And they have to be studied very soon. So because of this instability, when you have these markers, it hasn't been able yet to be available clinically, but it's promising. Now, I did mention a lot of names, and probably you're going to see these names when you go to the American Society of Nephrology, American Transplantation Congress. So I wanted to give in a nutshell, what is available right now. So we have 3 companies, one CareDx, one is called Natera, one is called Eurofins. We have a test called AlloSure, which is donor-derived cell-free DNA. We have an AlloMap, which is gene expression profile, as I mentioned, still final validation based on the KOR study, which we are involved in. There is Prospera, which is another donor-derived cell-free DNA. This company had TRAC, which is a donor-derived cell-free DNA, and TrueGraph, which is a gene expression profile I just talked about. And then they came up with a test called OmniGraph, which is a combination of both the gene expression profile and the donor-derived cell-free DNA. Now, a lot of us will ask the questions that which one to use, which one is more specific, which one more sensitive. There is no right or wrong answer. But the next slide is a bit busy slide, but it has a kind of a resume. On the right side, you have donor-derived cell-free DNA. You have the 3 types of donor-derived cell-free DNA available: TRAC, AlloSure, and Prospera. Each one has how much SNPs it can detect. And it shows what is the percentage cut off to use. So most of them are 1%, maybe VeraCore TRAC will use the 0.7%. In general, you can see that the sensitivity is not the greatest, the specificity maybe a bit better, but the most important thing is the negative predictive value, is that you can rule out by more than 90% if the test is negative that there's no rejection. And mainly for antibody-mediated rejection. Now, the one test of gene expression profile available called TrueGraph, it detects 120 genes, as I mentioned. The problem is that the reporting is only TX or not TX. Is the gene are quiescent or not quiescent? But it has a good positive negative predictive value for the TCMR. And you have this test called OmniGraph, which is a combination of both the TrueGraph and the TRAC. So it's a combination of both gene expression profile and T-cell and donor-derived cell-free DNA. And this is how sensitive, specific, the negative predictive value is good, and maybe have a better positive predictive value. Now, how we can use this in real life? So I have here 2 examples of cases that the donor-derived cell-free DNA did help. First case, 62-year-old. Actually, he was a physician, polycystic kidney. He got a second transplant, failed first transplant due to rejection. And so as you can see here that even though that his creatinine was close to normal, baseline was around 1, he had elevated donor-derived cell-free DNA. I had to convince the patient that we need to do a biopsy. You know, he's a physician. He knows that, you know, my creatinine is normal. Why would I do the biopsy? So I did explain to him, okay, your cell-free DNA is high. And in fact, he agreed to have the biopsy and showed BAMF2A, ACR. He was treated. A year later, again, his GFR was 90, but his donor-derived cell-free DNA was high. It's more than 1%. Again, another discussion about doing another biopsy, and the patient did agree, and we had borderline this time. So this is a real-life example that even though with a normal baseline creatinine, a high level of donor-derived cell-free DNA can help in surveillance for rejections. Another case. This is 66-year-old. Again, this is her second transplant. She has a very high PRA of 100%. The problem is that she has tricuspid and mitral valve repair, and she's on anticoagulation. So in those cases, we typically don't do surveillance biopsy because you have to stop and reverse anticoagulation. And this patient, as you can see here, at the time of transplant, her creatinine was high, and then as a follow-up, her creatinine was maybe along the baseline of somewhere between 1.5 and 2. So she was at her baseline serum creatinine. But then we did a donor-derived cell-free DNA, and it showed it's 5%, it's elevated. So we talked to the patient, we need to do a biopsy, we need to reverse the anticoagulation, get the biopsy, and we found borderline rejection in this case. So this is another example how the donor-derived cell-free DNA, if elevated, even with a normal serum creatinine, can help for early detection of rejections. So what we do in practice, we test all our patients 1 to 2 months after transplant, serially in this this month, maybe about 7 times in the first year, and at least every 3 months in the second year. Now, why we do not test immediately after transplant? Because there's some injury, ischemia reperfusion injury after the transplant. So you have to wait about 2 months to start monitoring for the cell-free DNA. And after the biopsy, because during the biopsy, you injured cells. So you want to make sure that you're away from any intervention before you test for the donor-derived cell-free DNA. Having said that, there are still questions to be answered. Can we detect BKVN or differentiate between rejection and BKVN? What if we have a combined cell-free DNA and gene expression profile? What will be the validation of these tests? What is defining more the role of monitoring in subclinical rejection? What about other solid organ transplants? So right now, there are other tests that can detect heart, liver, and lungs as well, but still in development. And what about validation in combined organ transplants? This is an important question because right now, 1 of every 5 patients coming for kidney transplant in the United States, it's either for combined organs or had a previous organ like heart, liver, or lung and developed CNI nephrotoxicity, now coming for a kidney transplant. And what will be the role of urine biomarkers in the future? And with that, I am very thankful and open for questions.
Thank you very much, Professor Ziad, for this very comprehensive presentation. And actually, your talk has raised a lot of very interesting query points to be answered. First, I would like to clarify from you about the genes which are upregulated and the genes which are downregulated, to segregate the process of either rejection or tolerance or fibrosis or whatever. I understood from you that you are depending on upregulated genes. Is there any role for downregulated genes? This is my first question.
So, your question, Dr. Gamal, you are always have this, I have to say, futuristic ideas and futuristic views. So the question about which genes are highly regulated and which genes are downregulated to monitor rejection can be answered, and hopefully will be answered by a study by trifecta study. And the trifecta study is basically, it's led by Phil Halloran from University of Alberta. And we are part of this group called Intercomics Group, where we don't rely on serum genes. We use technology called molecular microscopy, or MMDX, where actually is checking the genes in the biopsy itself. There's a microarray that you test for the genes in the biopsy itself, and you can have a
عمرو please كلمني بعدين أو ابعت رسالة.
What? So basically, this study is still, like, there are multiple studies. The trifecta study is like many publications from the trifecta study, is that they're checking the genes in the biopsy itself to avoid the subjective and the intrapersonal variations in reading the biopsies. So I would encourage you, this is it's a whole different topic to talk about the molecular microscopy and the MMDX and which genes are up or down regulated, because they check the genes in the biopsy itself. And I have the pleasure to be part of this group where we do a biopsy And you don't need, you know, the common practice of having 10 gloms or 2 medium-sized arteries to have a good satisfying specimen for the Banff criteria. Actually, you only need 3 to 5 millimeters. And it doesn't matter with the cortex or medulla. And you put this specimen in the RNA later, ship it to University of Alberta. And Dr. Halloran has this algorithm to measure these gene expressions based on this specimen and get a more detailed and better idea about the interstitial fibrosis, the interstitial inflammation, and the rejection. So, Dr. Gamal, as I mentioned, you are very futuristic. And to answer this question, we have to talk about this study, the molecular microscopy.
Yeah, my second question, at what stage when the biomarkers truly replace the need for a biopsy? If you find that gene expression, why don't you proceed directly to treat it? Why do you still refer again to the biopsy with possibly searching for new biomarkers among the biopsy to detect the rejection?
So our technology didn't reach yet the level of, because again, biopsy is the gold standard. The problem is that, and I can tell you this from my personal experience, because I do close to 300 biopsies a year by myself, because we do surveillance biopsies. I have these false positive results from the donor-derived cell-free DNA. So I have patients with 1.5% donor-derived cell-free DNA. We do the biopsy and we rule completely. There is no rejection. So the technology is not yet that precise.
I understand.
Yeah. The need for biopsy.
Yeah. My last question for you. If you perform a biopsy and you find borderline rejection, your answer to me now is that we should treat the borderline rejection. Yes or no? Because sometimes it is debated. I would treat a borderline rejection in the biopsy.
I agree with you, and I do the same. I do the same. If I have a borderline rejection, I know that some of my colleagues, if the patient has a normal or close to the baseline creatinine, they may not treat, but I would treat. Maybe I would treat with pulse oral steroids, not an IVMP.
Sure.
But I'm very advocate to treat the borderline. I'm very advocate of repeating the biopsy after treatment, maybe by 3 or 4 months.
That's great. Do we have any questions, Dr. Yasser, please?
We don't have still any questions on the chat, but I have a question, Professor Ziad, and you started to answer in the previous answer, Can you stress again, please, if there is any value or the values of these biomarkers on treatment selection of a specific drugs more than other? Not only in the diagnosis?
Not really studied. So they are not really studied whether you have to modify the immunosuppression. We know that you have to optimize immunosuppression if you have this elevated donor-derived cell-free DNA. But can you change the drugs, or would you change the drugs? I think there are other variables that mandate which drugs to be used in these patients.
But till now, we know these biomarkers cannot tell if it will be more useful to use this or that drugs.
No, it is useful to optimize the dose. Maybe you should run the tacrolimus instead between 5 and 7. You can run it between 8 and 10, for example, if you see that this marker is going up.
Okay.
I think, Dr. Yasser, there are probably development of other biomarkers, particularly those of the B-cell derived DNA markers, and they might signify the occurrence or the presence of a state of tolerance. This might be helpful to modify the immunosuppression and occasionally to consider withdrawing immunosuppression in very selected cases. But this requires, as I was speaking earlier, about upregulation of specific genes and downregulation of others. And there are, for example, the 3 gene test of tolerance of B cell derived markers. And this was a paper by Noel in 2018. And it indicated that there is upregulation of 3 genes in spontaneously tolerant kidneys. And this is one of the papers indicating that there are special biomarkers of tolerance in addition to the markers of rejection. And as Ziad was just mentioning, that there are also other biomarkers of fibrosis, and probably this might mandate antifibrotic therapies among other tools of management of IFTA. So I think this field is in the phase of progression and development, and probably we'll hear more in the future about this aspect.
Now,
hopefully that we
maybe along the same line, we have a study here with a company called VerityDX. And the problem is that this study is that we are detecting certain, as you mentioned, we're trying to wean off patients from immune suppression, and we try to differentiate which patient can be weaned off the immune suppression by certain pre-transplant biomarkers. It's there's some logistics involved. First of all, is that you cannot, you don't have the time for deceased donors to do this. Remember that 60%, 65% of transplantation in the United States from deceased donors. So if you have these markers and you try to find these markers before the transplantation, it's very difficult logistically. So it can be done for living donors, where you try to wean off the immune suppression. But there are, as I mentioned, there are studies that I actually also involved in called from VerityDX that would try to see which patient can be weaned off the immune suppression based on these biomarkers. There was another test called ELISpot. ELISpot was based on the T cell cytokines, and but ELISpot hasn't been able to come to clinical practice. It was one of the CTOT trial, clinical trial of transplantation, but it hasn't come to clinical practice.
I think it's all these are in the field of development.
Okay. My second question, and you started also to answer Professor Ziad, if there is a difference between living related and diseased donors in application of these markers, or the same?
I have not seen either in my practice or from the clinical trials that there's a difference in the level. However, I will tell you this.
Yes.
Yes, and you always ask these very specific questions.
Yeah. We have some questions to Professor Gamal.
Okay.
Would like to continue?
Ziad, Ziad covered the topic very nicely and opened the scope for future validation of these tests in the clinical practice and among the biopsy data as well.
We have Professor Gamal, we have Professor Sahir Al-Khashab wants to comment. And
yes,
Sahir, please.
Hello, Dr. Ziad. It's been a long time since we've heard your voice.
Very long time, Sahir.
You've been missed. I want to ask you a question about this new marker, whether its level differs with time. For example, what I mean, cyclosporin, if you have a C2 in the first year of transplantation, which is 200, you increase the dose. But if I find this level in the 6th or 10th year, I don't increase the dose. So does this marker level differ with the time or with the aging of the kidney?
Remember that our experience in this donor-derived cell-free DNA is about 3 years.
Okay.
And I have few cases where the marker was high for patients, for example. For example, we had patients who were transplanted 6 years ago, and we were not sure about their kidney function, like creatinine is very fluctuating. and we didn't know, should we or shouldn't do a biopsy? So sometimes we order these tests, we get a high level of cell-free DNA, and then we do a biopsy for that reason, and we found that there is, still valid. 1%, above 1% is still valid to rule in or rule out rejection, mainly or namely antibody-mediated rejection. So to answer your question, it not from the clinical trial, but from the clinical practice, it's still valid for long term.
And do you follow up the level after management of the rejection process by increasing the immunosuppression or treating the rejection process? Do you follow up the level of DNA?
Yes, we follow as long as the patient is still following with our transplant center. Remember that some of those patients, most of our patients are followed for the first year, maybe the second year. Beyond the second year, a lot of those patients, they're not following with us. But if the patient is still following with us, we order these tests, we follow this and see if the treatment did improve or no. But, there's a catch here. The one thing I haven't mentioned is the price of these tests.
Yes, this is as usual. You answered before.
This was my second question, Dr. Ziad. The price of this test.
Yes.
So
anyhow, regardless of the price, so you need to follow up or not, regardless of the price.
Yes.
Okay.
Okay, that's great.
We have a question on the chat from Professor Noah Shaheen, and I would like to welcome her.
اهلا بحضرتك. اهلا بيك. مساء الخير دكتور جمال، ازي حضرتك؟
اهلا دكتورة نهى، اهلا بيك.
ازي حضرتك؟
Ask your question.
بص حضرتك، انا كنت عملت محاضره عن موضوع الدونر درايف سيل فري دي ان اي، بس طبعا من ناحيه الكلينيكال باثولوجي بوينت اوف فيو، لان انا استاذ اميونولوجي. فكان عندي سؤال بالنسبه للستدي، طبعا حضرتك بتقول عليها الدارت ستدي. my impression انها كانت mainly بتفوكس ان هو very effective in the presence of clinical dysfunction، وعلشان الeffectiveness ده حاولوا بعد كده في الادميرال ستدي ان هم يimplement donor drive cell free DNA بالسيرفي كانه سيرفيلنس تيست زي ما حضرتك قلت، وبرضه شركه اللي هي كاردي اكس اقترحت السكادجول اللي حضرتك بتقوله. اول
please put all the statement in English because it's recorded for other candidates.
Type to repeat the question in the effectiveness of donor-derived cell-free DNA for in the presence of clinical injury, and its use as a surveillance test was suggested in the Admiral study, and later on there were several studies denoting that it might not be very effective for surveillance. It's excellent in the presence of clinical dysfunction only.
So that's why I brought up the radar study, that it has maybe some implication if you have a patient with normal baseline creatinine, having a biopsy, and even if the cell-free DNA is less than 1%, this is where they show that if it's more than 0.5%, they have high likelihood of developing de novo DSA, graft dysfunction, and rejection in the future, or less than.
Now, almost the same results as the Admiral study.
Yes. Now, having said that, the largest trial for donor-derived cell-free DNA, which is basically what you're telling me about AlloSure from CareDx, is KOR study, which we are right now, we are still recruiting patients, control patients in this study, which may answer your question. Now, the KOR study has 4,000 patients recruited, 3,000 with rejection and 1,000 as a control. Actually, 1,000 the control arm. So the KOR study may answer several questions. One, for this particular question you asked, is about what about those patients with a same baseline serum creatinine? Does the cell-free DNA help in surveillance or no? Two, the KOR study has both the gene profile, the donor cell-free DNA, and using what we call iBox, which is an AI, artificial intelligence algorithm, where you have both these two tests, and the artificial intelligence algorithm can predict what will be the survival of this graft in the next 4 or 5 years? So I agree with you that yes, we use it as surveillance. Maybe still the data did not bona fide the use in surveillance, but there's a good promising results from the KOAR study that it could be used for surveillance.
Okay, thank you very much.
Thank you. Another question from Dr. Masoud Khairi. Is DDCF DNA differentiate between PK and rejection? Does it differentiate between PK and rejection?
So Dr. Dan Brennan is trying to answer this question, but to tell you the truth, I don't think that donor-derived cell-free DNA would be able to answer this question, and we may need to use gene expression profile as a complementary test to help, because gene expression is more specific for rejection than for BK virus nephropathy. And actually, I have a proposal from the company to study BK nephropathy, but I haven't had time to develop the IRB and the consent form for this study.
Okay.
It is very clear. It is very clear that all these biomarkers are still in the phase of development, and to me, they are complementary to that point in our clinical practice, and they cannot, at that moment, replace our traditional tools of diagnosing either rejection or viral infections or fibrosis. Do you agree with me, Ziad?
I agree. It cannot replace the standard of care, the gold standard of care, monitor serum creatinine during the biopsy. It only can do what we call fine-tuning. Those cases that...
Thank you very much, Ziad, and I hope you can have the time to come and present these topics in our meetings in Egypt in the near future. Thank you very much.
I wish to, yes.
Another question from Dr. Ahmed Farah, or A. Farah. And is DDCF DNA test taken from blood samples? And let me ask the question for myself again. I think the same question. You said that you take a very few minute sample of the biopsy with few glomeruli. So do you feel that it is versus the difference that we take a large biopsy or a small biopsy? Finally, we take a biopsy. So why not to take a biopsy?
Yes. Now I got your question.
Yes.
All these markers I talked about, and look at this slide, they're all taken from the blood.
Yes.
And it even shows that how much blood draw required. You need at least 10 milliliter in one Paxogen tube. Now, the question about how much of the biopsy, this is a different study called the trifecta study, where Dr. Phil Halloran is looking for the gene expression in the biopsy. And it's by using a technology called molecular microscopy. And this one is the one that, in addition to a regular core, you take an extra sample for the study where you only need 3 millimeter. Okay. So that's a different study, but it's not in practice right now. It's not the clinical practice, not our standard of care right now.
Okay. Okay. No more questions and no more comments.
My last comment, Yasser, we are thanking you personally for your great effort in bringing up to us all these developments, and also bringing us our great friends who are abroad everywhere. Thank you very much, Yasser.
Thank you, Professor Gamal, for joining us usually and enriching our meetings with your great experience.
Thank you.
You can close the meeting.
Okay, thank you very much, everybody. Welcome.
Thank you.
Thank you.
Thank you. Now we can close this meeting, and thank you, Professor Gamal, for moderating and being the leader of this meeting. Thank you, Professor, for joining us and for this fruitful meeting and giving us this very valuable information and new information, hopefully, to have you next time for the clinical applications for these markers, and to be very soon. Excuse me to close this session. And before close, as usual, I will announce about the coming session, which will be ESNT Clinical Forum by Manufia University next Wednesday, inshallah, 9 p.m. in our usual time. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله.
Thank you very much.